Now we're going to talk about the ADLs and the IADLs. ADL questions assess a patient's ability and not necessarily their actual performance. Willingness and compliance are not the focus of care here. So if a patient is non-compliant, that should not be considered, but if they are unsafe in what they do, safety is a key consideration in the ADLs and IADLs. Items address the patient's ability to safely perform these ADLs. You need to assess their current physical, emotional, cognitive status, and any activities that are permitted or restricted by a physician. Ability can be temporarily or permanently limited. So a lot of times temporarily, they may be weak after surgery, or they could be permanently limited by, say, a long-term illness such as stroke. You want to look at things like range of motion and impaired balance, any kind of memory deficits or impaired judgment. If the patient has impaired vision, if they have macular degeneration and they are losing their vision, this obviously causes a safety concern. And then environmental barriers. Do they have stairways, or do they have the narrow doorways and they can't get their walker through? What is the location of their bathroom or their laundry? Is the bathroom upstairs, the laundry in the basement? We want to look at the patient's ability, and we hope that their condition improves over time, but occasionally it may decline. And we need to base it off of what it is at the time of the assessment. If medical restrictions are in place, they can be imposed or lifted. And we may modify the environment to help them get better. That's what our goal is. We may institute grab bars in the bathroom so that they can get safely in and out of the tub. But one thing that you need to remember is that you can never assess what could be if the patient doesn't have the equipment in place. So they would then be more dependent on our assessment. We put those interventions and environmental adaptation devices in place, and then they become better, and then at our discharge they're in a better environment than they were before. If ability varies over time, you're going to choose the response describing the patient's ability more than half of the time. While the presence or absence of a caregiver may impact actual performance of activities, it does not impact the patient's ability to perform those activities. In other words, if the caregiver is not there, can the patient perform at the same level as if the caregiver was there? An example would be you go to visit a patient and they're in their sweatpants and t-shirt, and you ask, are these clothes what the patient normally wears? And they're like, no, my wife usually helps me get dressed in a button-up shirt and zip-up pants. Well, he is adapting his environment because he cannot dress himself with the buttons and the zippers, and so he just has pull-on clothes. So at that point in time, he is not independent. Even though he independently dressed himself in the temporary clothes, he needs assistance to dress in his normal clothing. So the ability for the caregiver may change, but the ability of the patient only changes with that caregiver ability. They cannot do it themselves. If the patient's ability varies between the different tasks included in a multitask item, you are going to report what is true in the majority of those included tasks, giving more weight to tasks that are more frequently performed. The scales present the most independent level first and then proceeds to the most dependent. You're going to read each response carefully to determine which one best describes what the patient is able to do. And my advice is to read from the bottom up, because our tendency is to mark the first thing that we see that we think that the patient fits into. Let's talk about bedfast. The OASIS guidance manual defines bedfast as that the patient is unable to get out of the bed. Okay, they cannot tolerate being out of the bed, either physically or they're restricted to the bed from the physician. There is no time limit on what time they can be out of the bed. If they are out of the bed, then they are not considered bedfast. Even if they require a Hoyer lift to get to the chair, they are not considered bedfast. Even if they're only out of the bed 5 minutes out of the day, they are not considered bedfast in OASIS terms. Now, they can also be physically. So here's an example of physically restricted to the bed. Patient with multiple system atrophy becomes severely hypotensive within a minute of moving from the supine to the sitting position and is considered bedfast due to the neurological condition which prevents him from tolerating the sitting position. He can't even sit up on the side of the bed because he gets so hypotensive that he falls over. In the ADLs and IADL items, M1800 and M1900s, what is the difference between willingness and compliance and cognitive, mental, emotional, and behavioral impairment? If a person is unwilling to bathe appropriately, resulting in poor hygiene, an offensive odor, or increased risk for infection, isn't the patient suffering from some sort of cognitive, mental, behavioral, or emotional problem that would cause his unwillingness and noncompliance? It seems that that would be a much deeper issue and be part of the psychological problem. Here's CMS what they say. A patient may demonstrate that they can safely ambulate while using a walker, but then as a matter of choice, they decide to walk without it. Another patient may demonstrate that they can safely ambulate while using a walker, but then consistently walk without it, forgetting that they even have the walker. And then you have those patients that have the walker and they pick it up and they walk with it. For the purposes of OASIS scoring, nonconformity or noncompliance should not automatically be considered indicative of a deeper psychological impairment. The assessing clinician will have to use clinical judgment to determine if the patient's actions are more likely related to impairment or a personal choice made in awareness of the potential related risks. The response related to assistance of another person includes those patients actively participating in performing a task, but needing assistance of one or more persons to safely complete the included tasks. And now, assistance of another person can include supervision. It can include the hands-on assistance of that person, or person or persons. Or it could even be just a supervision or a cueing. Maybe they just say, Mom, don't forget to use your walker when you walk. Service animals counts as devices and not as assistants. So if you have a service animal, you have to count it as a device. M1800 grooming. What is the patient's current ability to tend safely to personal hygiene needs, specifically washing the face and hands, hair care, shaving or makeup, teeth or denture care, or fingernail care? These are marked at start of care, resumption of care, and discharge. You're going to consider the frequency with which selected activities are necessary, such as washing your hands and face. You do that more often than you probably do that every day, as opposed to fingernail care, which may be done once a week. Patients able to do more frequently performed activities should be considered to have more ability in grooming. If the patient requires a spotter for safety, though, you need to mark response 2. M1810 and M1820 are kind of the same question, except one is asking upper body and the other is asking lower body. The time points for these are start of care, resumption of care, follow-up, and discharge. It's going to identify the patient's ability to dress themselves, to put on and off clothing, and clothing that is routinely worn. This specifically includes the ability to manage zippers, buttons, and snaps if these are routinely worn. So you have to determine what is routine clothing for this patient. Just like the example I gave you earlier about the patient in the sweats because his wife's in the hospital for 2 days, and he normally wears buttons and zippers, but she helps them. So you have to assess the patient. What is the routine clothing for this patient? Do they normally stay in their gowns, in their house coats? Are they able to put on and off their pants, especially if they're in a wheelchair? How is their ability to especially dress their lower body? So what is their normal clothing? What is their routine clothing? Now, if the patient is in a gown and a house coat and they have no plans to return to button-up shirts and pants, then you would score them at the house coat and the gown, because that is their routine clothing as of now, because they're not planning on going back to the button-up and the zip-up clothes. Also included are prosthetics, orthotics, or other supportive devices applied to the upper body and lower body, such as splints or arm slings or TED hose or wraps or AFO boots. Any of those kind of things are considered routine clothing for these items. Now, I don't know about you, but I don't know many people that can even put TED hose on another person, much less an elderly person trying to put them on themselves. I really don't know that many that can. So you have several techniques you're going to use. You're going to use an interview technique. We're going to ask the patient and the caregivers what's going on, what is their routine clothing. We're going to observe what they're wearing. We may even go to their closet and have the patients go to the closet to see if they can reach their routine clothing. We're going to look at things like their spinal flexion, their range of motion, any arm strength, and any manual dexterity. Ask the patient to remove the body motions involved in dressing. Don't make them actually get dressed, but maybe they can show you how they can put their arm through a shirt or how they reach down to pull up their pants. A question. The patient's clothes are hung over the chair in the bedroom. Therefore, he is safe getting his clothes. Is this a permanent solution? If the clothes are adapted for the wheelchair-bound patient in the closet, is this a permanent solution? Can they then get those clothes independently if we've moved them and adapted their closet from the top rack to the bottom rack? The answer is, if a patient modifies the clothing they wear due to a physical impairment, the modified clothing selection will be considered routine if there's no reasonable expectation that the patient could return to that previous style of dressing. The guidance in M1810 and 1820 state that you assess the patient's ability to obtain, put on, and remove the clothing items usually worn. This includes things like the prosthetics that I talked about, corsets, I didn't even know they still made corsets, cervical collars, hand splints, TED hose, etc. All of those are considered clothing apparel. Do we include the other items like a splint if the patient doesn't usually wear it? If they have it on the day of the assessment, then you count it. M1830, bathing is a value-based purchasing question. Is the patient able to wash their entire body safely? This excludes the grooming, such as the washing face, washing the hands, and shampooing the hair. So let's look at all these items. 0 means that the patient is able to bathe herself in a tub or shower independently, including getting in and out of the shower. Number 1 is, with the use of devices, is able to bathe herself in the shower or tub independently, including getting in and out of the tub or shower. So basically, both of those are telling me that the patient is independent in bathing. They don't need any assistance from anybody. Number 2 is able to bathe in the shower or tub with the intermittent assistance of another person to help reach difficult to wash areas. That'd be your bottom, your feet, or if they need help getting in and out of the tub, or if they just need supervision. Remember, that is assistance. Supervision or verbal cues are assistance. Number 3 is the ability to participate in bathing themselves in the shower or tub, but they require another person at all times. Number 4 is unable to use the shower or tub, but able to bathe themselves independently with or without the use of devices at the sink, in the chair, or on the commode. So pretty much this one is independent too. I see a lot of clinicians mark this, but this is basically saying they can do it themselves at the sink. For whatever reason, they can't use the shower or tub. Maybe it's broken and they have to use the sink, but they're able to independently do it. They can do it all by themselves. They don't need any kind of verbal cues. They don't need any kind of setup. They don't need anything. They don't need any help. Now remember this is how they safely perform. So you have those patients that live alone that may do this, but are they doing it safely? So a lot of times I will advise agencies to look at their fall risk score first. What is their M1910? What is their MAC-10 score? If they've scored as a high fall risk, then they are very likely to not be able to perform these ADLs and IADLs safely. So, you may want to put those strategies into place. Number 5 is unable to use a shower or tub, but able to participate in bathing himself in the bed, at the sink, in the bedside chair, on the commode, with the assistance or supervision of another person. In other words, they're bathing outside of the shower or tub, but they need assistance from another person. We have a lot of patients like this. And then number 6 is unable to participate effectively in bathing and is totally bathed by another person. These are collected, this item is collected at start of care, resumption of care, follow-up, and discharge. Again, it specifically excludes the grooming items such